Hey, what's up? This is Dion Lewis, founder of Healthy Project Media and the host of the Healthy Project podcast. Join me as I speak with change makers who are doing the work and sharing their stories, insights, and innovations to close gaps in healthcare for everyone. Hello, community. Welcome to another episode of the Healthy Project podcast. I am your host, Dion Lewis. Today, I have a great guest in the building with me. I have Dr. Seun Ross. Dr. Ross is the principal advisor at Encoding Equity Alliance, a recognized expert in the implementation science and the elimination of structural barriers to health. Dr. Ross is dedicated to achieving health justice through evidence-based strategies that address health disparities at their root. So, Dr. Ross, thank you so much for being here. I really appreciate it.
Thank you for having me, Corey. I appreciate it too.
Yeah. So, before we get into our discussion today, can you tell the people maybe a little bit more about yourself? What really gets you up in the morning?
Um, I am a mother of two beautiful daughters. I have a huge dog, Titan. Those are the folks who get me up in the morning, and I think what gets me going is my work is really focused on making sure that everyone everyone walks into a healthcare environment knowing that they are going to receive the best care, the most optimal care, despite what they look like.
No, that's I love that. Um, can you talk? I know when we had our first conversation, we were just even talking about the idea of having you on the show. The topic of health justice came up, and can you tell me a little bit talk about what health justice means to you?
I think when we talk about sort of these terms, health equity, health justice, social determinants of health, I think the terms are often conflated. And it's really important to make sure that people understand what they mean. So, what health justice means to me is those things that prevent people from achieving their healthiest lives possible. And an example of that is particularly in what I will call medical racism, where people who are Black or minoritized populations are allowed or it is normalized for them to have poorer outcomes than others. So when I uh, think of the term health justice, it is removing those barriers, sort of those hidden barriers that exist, so that when I go to a physician or provider for care, or when someone white goes to a provider for care, that upon entry into that environment, we are looked at as equal, we are evaluated, assessed as equal, and how our um, what's the word that I want to use? How we are then um, not assessed, but how our diagnosis, that's the word. Our diagnoses are the same no matter what.
And as you say that, Dr. Ross, to me, as a warm-blooded human being, feels like that just should be very, very easy to do.
Yeah.
And as you're aware, and as we know, there are so many obstacles and layers to what you're saying to make that a reality for those in our community.
Yeah.
What has it been like in your experience peeling back those layers to get to the next part of this or the next layer of this?
That's a really good question, Corey. And I think it's the way you ask the question is really important in understanding that this onion has lots of layers. It is so complex. No one can say that they are working on just one piece of it, right? You have to consider all of the parts. I think it's for me, when I think of how to look at this, it's you have um, unconscious biases, you have structural barriers, you have systemic barriers, you have institutional barriers. all of those, which lead to the which lead to social determinants of health, which leads to the need for health equity, which leads to the um, folks like me working on achieving health justice. So when you think of it like that, you know that none of those four things that I have listed, institutional, structural, systemic, unconscious bias, are just, they're not easy. It is,
Hmm.
I have to tackle all of them at the same time almost in order to get to health justice.
Whew. That's to just thinking of that, of tackling all of that, and you
Yes.
say at the same time when dealing
Yeah.
with one of that is a full-time thing on its own. It feels like a lot, and it can feel overwhelming. But what I take from that is it's still necessary to do,
Absolutely.
and it's still important work. And a question I have too, Dr. Ross, when thinking about the different layers and the different pieces that you just kind of talked about,
Mhm.
sometimes it may feel like um, a well-intentioned program is thought of as, oh, we're going to fix all of those different pieces.
Yeah.
um, why do you think many well-intended efforts fail to achieve their goal at closing these gaps?
Yeah, I think, I don't think that anyone who is in this space, who is a provider on any level, have any nefarious intent, right? I think people
Right.
genuinely want to help and are genuinely putting effort into creation or ideating around programs that can help. The challenge is that, let's take a food program, for example. You have a group of people who are diagnosed, let's say, with diabetes or hypertension, and a health system decides that they are going to start giving them food. The challenge with doing that is that for that moment, right, you are meeting a need. That is the need of that patient in that moment. But that has not
Mhm.
addressed the structural barrier. That has addressed social determinants of health, right? But that
Mhm.
has not addressed, say, unconscious bias. That has not addressed systemic barriers. That has not addressed institutional barriers. That's not addressed structural barriers. You've only addressed sort of the social determinant of health, and you only addressing it for a short time. So when we think of these food programs where, institutions say, I'm going to give someone a bag of groceries, and they put a time limit on it, you at the end, once that person stops receiving that food, the disparity gets worse. It doesn't improve because you haven't looked at it holistically. Now, I know it's a challenge, right? Like, I'm not telling, I don't want to give people the impression that you have to do everything all at once. Giving folks a bag of groceries is necessary, it meets a
Right.
need. But my statements are to challenge health systems, community based organizations. While you're doing that, at the same time, you're lobbying for policy change, or you're advocating for policy change. You are looking at the structural barrier. So is it that this person does is not close to a grocery um, store? Are they closer to a corner store than a grocery store? Like, figure out what the root problem is. I always say, if you can continue to ask why, then you haven't gotten to the root. So
Mm,
the challenge is to continue to ask why until you get to the root, and then address the root problem.
right. And I feel like we all kind of see what the root problem is, but
Mhm.
sometimes it feels like, and I have to take responsibility because I'm in that space. The the root is ugly, but the social determinant we're trying to fix is very sexy in the moment.
Yes. Yes. Because that is it. It's one of those things where it is, sort of the cream on top that you can
Yep.
you can address that immediately. Um, Millions of dollars have been spent on health equity initiatives since 2020. And we know that the disparities have worsened since 2020. Health equity is not new. The federal government has been talking about this since the 80s, right? It's just become, to use your word, sexy in the
Mhm.
last couple of years. But when we think about why we've been talking about something for 40 years now and there has been no issues, is because the policies that are informing these things have not changed. And so when we talk about certain neighborhoods not having adequate access, when we talk about certain groups of people not having access, is a huge thing. Health insurance, when we talk about these folks who live in these environments not having things that are necessary for healthy living, until we get to that issue, then things won't change. And in healthcare, particularly for, if I can talk about one of the things that I am focused on right now, which is the inappropriate use of race in medicine.
Mhm.
Myself as a clinician, we're using those sort of coefficients or the different markers for years, for decades, as I counsel patients, only until recently realized that that is a structural barrier to health for minoritized populations. So it really is, Corey, doing the things that are sort of the cream on top, right? The things that are sexy, but always diving deeper and doing those things too. It cannot just be what's easy in the easier in the moment, because none of it is easy, but just easier.
Right. And I'm glad you talked about some of the work that you have done or currently doing, because a lot of the people that listen and watch this show are practitioners, public health, healthcare, that want to improve and learn. Okay, how can we're doing the surface stuff. What can we do to get to the root cause? And can you've successfully helped remove, like you said, race as a factor in clinical guidelines at multiple institutions. Can you walk us through how you achieved this? Especially the challenges and the milestones. Like, what was that like?
Yeah, I think, oh my gosh, Corey, this podcast will end up being 3 hours long if I try to tell you all of the things. But I think it's, in understanding how to get to that, right? To your one of your original earlier questions, the difference between health equity and health justice.
Hmm.
Health equity is closing gaps for people. Health justice is removing those structural barriers that lead to those gaps, right? And so as I was doing my work in health equity, realized that there is a structural barrier here that is preventing people from being healthy. It normalized poorer function in Black people, Asian people, Hispanic people, that just didn't make sense. So when you think of, there are groups, anthropologists, sociologists have always known that race is a social construct, not a biological one. And using that framework and applying it to medicine, which almost always treated race as a biological thing. When you take that framework, apply it in medicine, you realize that a person who has a lab result,
Hmm.
um, I should not have if you are white and if you are Black, because race is not an objective data point. Race is subjective. And so if I am, as a scientist, right, physicians, I would say, are, they study science a lot. If and providers, if we know that science is saying that a race is a social construct, why am I applying it in a biological way? And so that was the reason why we created the Regional Coalition to Eliminate Race-Based Medicine in Philadelphia, why I created it, and started peeling back that onion on EGFR, on pulmonary function tests, vaginal birth after C-section, a race-based anemia guidelines, urology stone score. I mean, there are numerous. Darshali Vyas had an article in the New England Journal of Medicine called Hidden in Plain Sight, which listed like 15 tools where race is used as a biological data point. And so, using that article, the framework of understanding that race is a social construct, not biological one, led me to creating this coalition. And the coalition is successful. Was successful. We removed, when all of the hospitals in the southern Pennsylvania and southern New Jersey region, all updated their EGFR equations. 700 people moved up on the kidney transplant list.
Wow.
63 were transplanted. When you have those kinds of numbers, like that type of direct impact to people's lives, you know that the work that you're doing is impactful. And so removing structural barriers. So now I don't have to, as this work is done, we don't have to ever worry about that being an issue anymore, because now Black people, Hispanic people will now receive the same kind of kidney care
Hmm.
that white people do. And, we say that Black people are disproportionately on kidney transplant lists, they're disproportionately receiving diabetes. Well, if we don't allow their kidneys to die by giving them a higher score than what is truly their result, then we don't
Right.
have we don't have that issue anymore.
Right. Man, and that is a significant number. Like that's a lot of lives
Yes,
saved solely
yes,
by going to the root cause of the issue.
absolutely,
Wow. Um
absolutely.
you talked a lot about, bringing different people to the table. When we last spoke, and how important is it to involve various disciplines? So like epidemiology, sociology, specifically to the health justice movement.
You know, in order for us to realize health justice, we cannot operate in homogeny, right? It
Hmm.
cannot just be physicians at the table. It can't trying to solve this issue for healthcare. And I am healthcare. For healthcare, it cannot just be physicians, it cannot just be nurses, it cannot just be, the people who are practitioners of health. We need to involve people who are experts in data, the epidemiologists. We need to involve people who are experts in, in how societies function, sociologists, anthropologists. We need these people to help us understand, like I mentioned earlier, sociologists and anthropologists have always said that race is a social construct. Applying that to medicine is what helped 700 people move up on the kidney transplant list and 63 get transplanted. Applying that to medicine is what will allow Black women or Black people to get FRAX scores and DEXA
Hmm.
scans to prevent them from, not prevent them, but uh, help us understand what their fracture risks are. And so having these different groups at the table we have a problem, and every all of these groups are giving their opinions and ideas about how to do it from their expertise is the only way that we're going to be able to move the needle on this. But it requires everyone at the table and not just one discipline.
Right. No, 100%. And right now, when I'm thinking about bringing different people to the table, and I'm specifically talking about this year 2025, a lot of people are afraid in this space. Like people are scared to talk right now, right now, in fear of saying the wrong thing, doing the wrong thing. But how should we, as healthcare professionals, public health professionals, um, In your opinion, how should we move right now, given the current environment where the work that you're doing is still important, and it can be the wording or the verbiage may be villainized in some situations.
Yeah, I think that first, I should say, I empathize with all of us in
Hmm.
this time. It is very difficult to know that you are doing good work, the right work, and um, there is a concerted effort to stop your work. So I empathize with all of my fellow practitioners out there who are doing the necessary work to achieve health equity in this country. I will also say that this work requires perseverance. This work requires resilience, and this work requires passion. And if we have all of those things, if we continue, the civil rights movement, Corey, didn't happen over the course of 4 years. It happened over the course of decades.
Mm.
I mentioned earlier that health inequities or disparities has been talked about since the 80s when really, the country really started collecting data. One thing I will say to my fellow folks out there is discrimination is codified in law. And we have to tie everything that we do back to law because it's law. And so if you are doing this work and you can prove that one group is being discriminated against versus another group, then that's a win. That's where the disparities come in. And so talk about your work in the form of disparities, talk about your work in the form of discrimination. The Affordable Care Act has a section 1557 that you cannot receive federal dollars unless you identify where disparities are and you work to close them. This work is protected by law. So I encourage everyone to become familiar with law, case law. Again, a nod back to we cannot do this work in these closed
Mhm.
environments. You need everyone at the table, all expertise at the table to help us continue to do this work. And another sort of nod to the civil rights movement, there were times they went underground, Corey. It wasn't
Mm.
always out front, in your face. So I encourage everyone to continue doing the work. If you have to go underground and in a way continue working, and because when it bubbles up, we will have the evidence and we will have the proof that health equity, working towards health justice, is beneficial for this country on a social perspective, on an economic perspective, and just on a human level.
Right. Oh, I wish I could. I just want to drop the mic right there. But I got one. I got one more question for you. It's really, what are the next steps in your advocacy? Like, we are there upcoming projects or goals you are particularly excited about?
Yeah, I will say that I am always excited about all of this, all of the work. As an implementation scientist, my focus right now is continuing to address the medical racism and removing those barriers to health in the form of clinical algorithms or clinical decision tools. My work with the Encoding Equity Alliance at the Council for Medical Specialty Societies is taking this work national and helping everyone understand that there is an inappropriate use of race that exists in all facets of healthcare and helping nationally identify where those exist, where they exist in clinical decision tools, for medications, for diagnostic testing, for screening, for assessment, identifying them, finding um, the appropriate data point to replace it, because race is really being used as a proxy. So what's the appropriate data point that which we should be replacing that with, and disseminating that across the nation to the point where race will be universally accepted as a social um, as something social and not biological.
I love that. Dr. Ross, thank you so much for being on the podcast today. Anybody listening or even watching that wants to learn more about the work you do, maybe connect with you, where can they find you?
They can find me on LinkedIn. I am not very savvy on social media in general, but I am on LinkedIn. And so please reach out, Seun Ross, and it's spelled Seun, last name Ross. Reach out and we can continue this conversation and pushing this work forward.
Yes, and I'll also make sure I have that in the description of this episode. But again, Dr. Ross, thank you so much for being here. And everybody, thank you so much for listening to the Healthy Project podcast. I'll highlight you next time. Hey, thanks for joining us on the Healthy Project podcast. At Healthy Project Media, our mission is to connect with the next generation of health leaders and innovators. If you're interested in advertising with us or exploring collaboration opportunities, please reach out at hello@healthyprojectmedia.com. We look forward to growing this community together. Until next time, keep pushing the boundaries of health.